Welcome, everyone. Great to have you with us today for office hours. Our guest today is Bo Bowman, who is our Vice President of Strategic Accounts. Welcome, Bo. How are you?
Thank you. Great.
Good, good. So let's jump right in. We're talking about referrals, and as we know, they are the lifeblood of some specialty practices and hospitals. Yet in some cases, the referring provider has to jump through hoops just to complete the referral, and that can be a real barrier, and it can actually make them shop elsewhere. And so even though the referring provider's office is short-staffed and they don't have the bandwidth to follow a complicated process, they have got to make those referrals. So today we're going to talk about how to streamline the process, take care of the nitty-gritty for the referring office, and how to be the most competitive and successful in the market. So Bo, first, let's establish the landscape for those who are with us today. What are the processes that can be streamlined for the referring provider?
Well, first, thanks for the opportunity. And yeah, this is a pretty germane topic to many of the clients that we serve and really any growing practice around the United States today that, kind of lives and eats and breathes on their incoming referrals. So yeah, lots of granular activity that goes on in the referring process because again, although not evil intentions, the payer is not always in line to make sure the practice gets paid, and this is what we have to do. So really it starts with what information the specialist office may receive in the form of a referral. A good specialist, maybe a cardiology office, radiology office, will have their own pre-printed referral forms that are available, and they'll make sure to distribute those well. Even with that process, by the time the specialist receives the incoming referral form via electronic or paper means, there's still a ton of information that's needed. So at Infinix, we use an insurance verification and eligibility process that really cuts down the delays and makes the process more simple. We use a cadre of online portals to ensure we're getting all the necessary information, not necessarily just for the payer and the particular insurance or Medicare Advantage plan, but also all the detailed medical necessity we may need from various hospital portals or various practice medical documentation to ensure the diagnostic or procedure that the referring provider wants done, has all of it needs to stand on its own 2 feet. So, again, probably the big thing there that you're going to see is just delays. And, where I think Infinix can come in or any good, revenue cycle firm can say, hey, here's all the pieces you need on the referral to ensure really a successful event.
I always like to talk about, actually how and what the logistics are. But before we talk about how an office, the steps that they take to actually establish those functions, let's take a step back and take a 30,000-foot view, if you will, and discuss the why behind all of this. Why is it so important for the offices who are taking the referrals to complete the prior authorization for the referring provider?
Unfortunately, diagnostic procedures and even in-office and hospital procedures go on and take place every single day without either a referral or an authorization in place. And unfortunately, that causes in the claims world, a fairly substantial denial. And a lot of times it causes a denial that's so severe the practice or the patient or the provider is not able to get what we call a retro authorization. So when you can't get a retro authorization, at the end of the day, the denial is going to stand and the practice is not going to get paid. Even worse, the patient can oftentimes get a very high balance bill or high balance statement, and then they're left to call the practice or to call the billing company and say, what happened here? My PCP referred me to my specialist. I did what my specialist told me to do. I had my diagnostic, and now I have this giant bill. So we've really done the patient a disservice on 2 or 3 levels. And so, really at the high level, what we're trying to do is keep patient care at the center, right? And make sure the patient has all they need And then secondly, we want to make sure, as a medical practice that's providing all the necessary claims work, that we get paid for the services rendered. So, at the largest level, that's it. We want to make sure we serve the patient, and we want to make sure the practice gets paid for services rendered.
So it all begins with prior authorization, right? That's kind of the funnel that everything
Right.
goes through to get any payment on the other end. So the specialist or the hospital is capturing the referral. They probably need to start doing this with the patient. So what's step number one to actually implementing that prior authorization process successfully, so there's a chance of it ending successfully?
Kind of back to the granularity that our group, or again, any good RCM group, is capable of. We have a team set up to where either if the referring provider sends a note to the specialist, again, whether it's on a pre-printed form or whether it's just a referring doctor's business card and tells the patient, hey, I need you to go see such and such, and give them my card, or whether it's an electronic referral that actually takes place through the two-party EMR through an HL7 interface. At the end of the day, the completeness of what's on that referral is very important, because that's the first document we use ultimately to complete the authorization. So we can't use our successful prior authorization tools and team if we don't have all the information we need on the referral. So we will come alongside the specialist, and we'll work with the referring provider where the information is coming from. And if there's something we need to help them with in regards to notification of the patient or notification of the payer, or using our portals to go out and get the necessary information, then again, we'll come alongside the specialist. Again, great examples are surgical offices, orthopedic offices, radiology offices, cardiology offices. There's an immense amount of time and labor and people that it takes to get the proper information in on the referral, and then to relay that into all of the requests that we make on the prior authorization before we send to the insurance company. And doing it right with the right detail the first time oftentimes gets us a quick response. And so we're not delaying the patient's care, which is probably, again, the most important.
You just mentioned something that I'm curious about. In the past, we've talked about what the best solutions are. Are they technology? Are they people? Are they technology plus people? It seems that in this most recent answer, you really were saying you've got to have technology plus people as a solution.
Absolutely. I don't know. I've been in medical practice management 22 years now, and we spend a lot of time training people, and we spend a lot of time training based on what payers, both governmental and commercial, are setting through their own rules, guidelines, and policy processes, right? And so at the end of the day, using automation in some fashion to understand the algorithms and the policies that payers and governments are putting out in regards how to properly set up a claim, get it authorized, and get it paid is extremely important. So again, we like to install some of the tools that we have with our insurance verification, eligibility, and prior authorization suite. At the end of the day, you basically have a long list of incoming referrals, and we want to apply the same discipline and the same diligence each and every time we get in. So that's where a good load of information has to be processed. So the human eye is going to miss something. We're going to input a number wrong, we're going to input the spelling of a name wrong, or an insurance type wrong. So the more we can automate those processes, load them up into portals, and electronically get approval from the various payers for the necessary prior authorization, then the faster, again, we can process, bulk authorizations and get the patient to the diagnostic they need in a quicker fashion.
Go ahead. I want to go back to one other thing that you said that was really interesting, and that was not only patient portal, but the fact that a large bill is going to end up with the patient. Do you think that the majority of physician offices, the coding and the billing people, have that level of awareness that eventually this may end up in the patient's lap with no recourse?
Yeah, absolutely. So I do think the majority of the offices, either that I've been associated with or that we come across in either our consulting or engagements, they're very smart. Many of the practices we either work with or will have the opportunity to work with in the future, they know what's going on and they know how to do the necessary work. Unfortunately, you get spikes in referrals, right? Healthcare is very seasonal, right? So we see quite a busy time from, October to the end of March, and then we go into a little bit of a lull. So during those spikes is when we see, the real issues. And so, really at the end of the day, we have to have processes in place. And if we don't have solid processes in place, that's when it does make a lot of sense to bring a vendor in and say, hey, we really spike here, here, and here. We've had a hard time keeping the necessary labor force in place. Can you guys help us, during some of these, very difficult high-end, high volume times. And so a lot of times what happens is the process happens so fast from referring provider to the actual diagnostic specialist to then the patient will call in and will, sometimes say, hey, I can only do this diagnostic on this coming Friday. So at that point, the office may not have caught up, right? They still may be deep into a queue, but this patient's been prioritized by the doctor or has been prioritized by the surgery scheduler or whatever it may be. Well, at that point, it's a bit late, right? The doctor has had their medical assistant or a clinician call the patient and get them prepped for whatever the diagnostic may be. Oftentimes that means fasting the night before. And, they're off to the races, and here that diagnostic happened Friday morning, and Monday we get back to the office and oops, we didn't have an authorization for that one. So again, all of those kind of parties have to work in symphony, and the practice has to have, I would say, excellent decision-making stops and algorithms in place, i.e. the patient doesn't make it to their diagnostic if the authorization is not in place. And sometimes those things are hard to enforce in times of spiked volume.
Interesting insight into what the practice is going through. Tell us where, in all of your years of experience, where have you seen this done successfully? And what was the secret sauce behind their success, if you can boil it down to that?
Sure. Well, let's answer the question up front so I don't belabor. So the ability to repeat the same algorithmic information, get everything you need, and then be able to, most of the time, electronically execute on getting the prior authorization using the correct information, meaning that we've verified the patient's insurance, it's accurate. We've walked through, where the patient is in their deductible and what they may or may not owe, so we can help with patient responsibility, right? We can help any office set up a patient responsibility information and tracker. But that's the immediate answer to your question, is the ability to repeat the same thing over and over and over again and have the right tools between both electronic and regular labor means to do so. Now, probably in my own career where I've seen this be most helpful is cardiology and radiology, right? You've got to have an authorization for any cardiac diagnostic, and you've got to have an authorization for most either procedures or diagnostics that run through a radiology group. And so I think at Infinx, we've been real successful with our partners that provide care in those specialties. And again, they've met us halfway and we've met them halfway in regards to, hey, this is all the information that we need. We'll help you build the interfaces to make it run electronically. If we can't afford or we don't want to do the interfaces, then we'll come and we'll sit elbow side with your team and we'll train them on everything and every single piece of information we need to properly go out and swiftly get the prior authorization done. So, but anywhere from, we can help anywhere from a small three to 6 man, all the way up to 600 man radiology service, or a medium-sized cardiology group, 8 to 28 providers. Almost everything, groups like that, and throw in orthopedics and any of the major surgical specialties. All groups like that are, they're going to live and die on if they got the prior authorization, if they did it timely, so they can provide the necessary service. And it takes quite a bit of back office talent and labor to get that done. And I think that's where we have an opportunity to come alongside as a vendor and provide some value.
So is there a cardiology service that you can give us as an example of a successful implementation?
Yeah, we service cardiology groups within the HCA family, within the Memorial Hermann family, within the Catholic Healthcare Initiative group, just to give you some examples of all kind of health system cardiology integrated type groups. And so what we've done is not only work with the cardiology group, but then work with their referring offices. So we have a list of all of their referring offices, and we know the trends and the patterns and the volumes that come in. So then we know how to staff up our teams, right? So we know how much volume's coming in. And so again, we'll work real closely. And, it's very common diagnostics that they're trying to get authorized on. It can be more complex. For instance, if it's an electrophysiology procedure, we work with many electrophysiology groups around the country, and you'd have to go and get somewhere between 12 and 15 codes, authorized for an ablation or a Watchman procedure, or something more complex in the electrophysiology arena. And we have the teams and the coding expertise and the knowledge to handle that. So I think that's why we've been successful in the cardiology space.
So conversely, let's talk about the practices who aren't successful yet, and they're still struggling and are in pretty deep water. What happens when they don't have these processes in place, and yet they continually get referrals and are trying to live, and grow their panels with referrals?
Again, I'll answer the question directly, and then provide some of the I guess reference documents. So you end up having a massive cash problem, right? We'll see when we go and do a health check on a practice, or a health check in maybe cooperation with a private equity backed group or a health system backed group. And, if we see a real, if you will, zigzag line in their monthly collections, or maybe a decreasing trend in their collections, we can almost immediately point to what's going on with your authorization process, what's going on with your insurance verification eligibility process. Are you paying close attention to the significant payers that you're servicing, whether they be governmental or commercial payers? And then, from there, we can start kind of, putting the pieces of the puzzle, back together. But very often, your accounts receivable will just start growing and growing and growing. And typically the principals of a practice or an associated stakeholder will say, hey, how are we doing on that accounts receivable? It seems to be stacking up. What's going on? Well, without taking a real fine, kind of microscope to what's going on, you can make some assumptions. There's obviously issues, and that they may be providing care that they're not getting paid for. And again, that's kind of where we come in, is we can come in and do kind of a full analysis and show you, hey, you're getting paid this for these codes, but you're missing out on all this other revenue on these codes. And that's what's creating your denials. And so, a lot of offices, whether small or large, have a nice back office team that's working denials. You even have hospitals that have entire denial management teams. And I guess at Infinx, we look at that and go, you should be real careful about how much labor you invest into a denial management team, and maybe think more about investing more time, more effort, more energy in the very upfront process. And let's get it right up front, so we don't have to invest so much time and energy in working those denials. Because I don't know, in today's claims management inventory, kind of what we're seeing across the board, you really shouldn't have less than, say, a 3 or 4% denial rate on all the claims that you're processing. But we see many practices with 12, 15, even 18% denial rates. And a lot of that is because they don't have the tools to get the authorization or the upfront insurance piece done correctly. And if they don't have that labor, then they just tell themselves, no big deal, we'll get denied on this first pass, but then we'll fix the claim and we'll get it paid. Well, sure, maybe that's the case, but you're also delaying your cash from, maybe receiving it in somewhere between 17 and 24 days. Maybe you're delaying it now to 62 days and 64 days. Well, your bills get hard to pay and your compensation plan gets hard to, justify if cash is taking, 2 to 4 months to come in the door. So it ends up touching every piece of the practice if you don't treat that upfront prior authorization piece correctly.
That's really, those are high numbers, 12 to 18%. I want to remind everyone that if you have questions, please write it in the chat and we'll ask Bo. So let's go to the big question, which is how do you see either the implementation or the lack thereof impacting referral patterns, and an office that does this well, is this a powerful enough factor that it can change referral patterns to the benefit of the specialist or the hospital? Because, that's always the mystery. Like in any healthcare system, what are the referral patterns? Where are they? How can we change them? Can we push them? Is this singular factor something that can start to change that to the benefit of a practice?
Absolutely. I think in towns where you've seen, say, large primary care groups do various collaborations, big market towns, places like Dallas, Los Angeles, Houston, lots of areas in Florida. What we've seen is that, the PCP, as they start to gain power and make their groups larger and larger, they're the ones end up interviewing the specialists. And they're saying, hey, we're going to send you a referral with all this information because we've looked at your clinical data and we think you're a good specialist. But when we send you this, it's our expectation that we're handing over the care of this patient and that you're going to have all the necessary, inputs, policies, procedures, and team, to properly complete the authorization and get this patient to the necessary diagnostic they need to get to. And a lot of times, PCPs these days are often compensated on how well they're medically managing the patient, right? Versus just living on their, fee for service that comes in. So if that specialist, really, they're only going to get 1 or 2 tries, 2 at the max. So if that specialist doesn't do a good job, based on how that referring doctor sees that going down, and again, they're going to look at, time to schedule. If you're that referring in doctor, if you refer something out on Wednesday and patient's not sick, but they're not healthy, you'd like to see the diagnostic get done, hey, that week, Friday, maybe Monday or Tuesday at the latest. And, if you hear back from the patient the following Wednesday that, hey, a week's gone by and I haven't heard about if my authorization is done and if I'm going to get that, scheduled with my specialist, well, then that PCP is never using that group again. Right. And so, then you've got the health system, maybe, that's encompassing all of that. And so at the end of the day, there's a pretty strong symphony that has to go on with either the health system or where the diagnostic centers are located, the specialists that use those, and then really the referring PCP network that, decides how and where the patient's care is going to go down. And so there's a strong triumvirate there that all has to work together to ensure there aren't delays in care and to ensure, at the end of the day, the revenue cycle is held complete.
Question from one of the people who's with us today. I work as an outpatient same-day surgery and observation coder for a hospital and know that the prior authorization process is quite cumbersome. Many times those doing the pre-auths in our insurance department will check with coders for possible CPT codes for planned procedures. Mm-hmm. We do our best with the limited information we have, but mm-hmm. It is not guaranteed that will ultimately be what is coded once full operative report is available. Are surgical cases a big challenge for your company as well?
No. Surgical cases aren't a big challenge for us because we do prior authorization on surgical cases all day long. And we do prior authorization on radiology and cardiology and orthopedics. I think the key there is making sure that clinical teams, i.e. It may be the charge pass group, the folks that are actually, queuing up the charge entry team that then, have some sort of coordination with the coders. And so, for instance, with our group, we have specialty coders for each service that we end up, kind of working with. So maybe a great example today is we've been working with a lot of cardiothoracic surgical groups as of late, right? So cardiothoracic surgery is a little tricky because you go in for maybe it's a single bypass or a double bypass, or maybe it's a vein or a vascular treatment. And when the surgeon actually gets halfway through the procedure, he or she then realizes, oh, well, we also have to go do X, Y, and Z. So, with our group in that instance, we have a couple of coding teams and coders that all they do is cardiothoracic surgery. So when we go to get that authorization, that coding team is looking at it. They're looking at the care plan. They're making sure the medical necessity documentation supports the surgeon's desire to do that bypass or to do that double bypass or whatever that looks like. And then what we'll do is we'll go out and get an authorization for everything that could happen on the table in that event for that patient. And so what we like out of that is it's a little bit more work. But for the person asking the question at the end of the day, we take it that extra mile. So, a couple of things that ensures the patient's not going to get, some sort of either out of network or service that, was rendered and wasn't authorized. And then at the end of the day, both the hospital and the medical office are going to get paid for the fees, for the fees and the services they rendered. So you've got to go that extra mile and you've got to coordinate that care at the coder and office and hospital level.
Great, thank you. Just to, and a follow-up, just to clarify, the rendering and servicing provider should be responsible for the prior authorization. Why not the PCP or the referring provider? We are a mobile diagnostic X-ray unit and rarely are provided the clinical criteria needed for prior authorization. Also, most of our patients are seen the same day we receive the order.
Again, the referring providers are, they're typically, like we talked about, they may be community health PCPs, they may be nurse practitioners and APNs, often 4 or 5 of them overseen by one doctor and living on a narrow and thin budget with a small back office, right? So, rarely are we going to see the actual referring provider take on the burden of getting everything necessary done for that patient's potential diagnostic. So again, Infinx has a pretty deep relationship with some of the largest radiology groups across the country just for what this kind of question is about. And that is, for a group, we'd come alongside of them and kind of study where their referrals are coming from. And we can do things as simple as say, well, we're also going to need all of these fields of information. Is there an electronic way to get that? Is there a tool out there that we can help set up to get that information? If there's not, it has to be manual. Then we'll work on, setting up manual processes to get that information. But at the end of the day, kind of like we said in the middle of the talk today, we want to work with that referring provider for the specialist to help them send us the same repeatable information every single time that's accurate. And, you have to kind of get in there and work with that incoming provider to do it. As to at the end of the day, why the diagnostic mobile unit has to do that and not the referring provider. At the end of the day, the referring provider has no technical revenue or real professional revenue associated with the diagnostic getting done unless they were doing it in their own office, which they're not. And so they're not going to invest in the the time, labor, energy, and technology it takes to get it done.
That's a good point. That's a very good point. Thank you for that. We have one more here before we have to wrap up. For accounts receivables, we find that they're very granular and that we really don't have the depth in our office to really handle them effectively. How would you recommend, what's the first step that we take to try to get some help like what you're talking about today?
Sure. We have a real nice suite of accounts receivable services. And, again, the first thing we'll come in and do is a health check. And when I say a health check, I mean really a financial review of your accounts receivable. We'll look at the aging. We'll look at, where the major denial trends are. And then from there, we'll kind of make a plan, and that plan will be, hey, we'll look at what cash is immediately out there as collectible, the low hanging fruit, if you will, and we can put some teams on that to start some of the work down process. Some of that we can do, pretty easily. We can export claims data from any system and work on it like that. We can work directly out of the client system if that's approved and allowed, depending on what's going on. And then for some of that older AR that, say is Medicare claims, but is less than 12 months old and is workable, we like to sort that by claim amount from highest to lowest. So we'll go out there and immediately work the high dollar stuff and see if we can liquidate some of those claims quickly. And for those ones that can't, then we'll walk through with the client why they can't be paid, and then work through the client on what an intelligent write-off strategy may look like.
Excellent. Well, we've reached the end of our time. Thank you so much. You've given us such great insights, kind of bookend to bookend. So this has been very insightful and very helpful. And I thank you for your time today. It's been great.
Thank you.
Thank you very much. Thank you, everybody, for joining us.